So today I'm going to be talking about HHV6 and allogeneic bone marrow transplantation. It's a subject that you may get one question on your board exam for. There's really only kind of two things that they ask about, and I'll point that out. But anyone who's going to go work at a transplant center or a hospital that has a oncology program will probably encounter this virus as well as questions. And so it's important to kind of know the literature behind it, as well as some of the common questions, pitfalls, therapeutics for it. I will be using some of the Poll Everywhere software to do some general questions that I encounter in practice and that you might, especially Moffitt, during your bone marrow transplant rotation. I have no conflicts of interest reported for this talk. And just a general overview. So we're going to go over the epidemiology and the life cycle of this virus, talk about certain risk factors for development of disease after allogeneic stem cell transplantation and what sort of presentations it might actually have, therapeutic options, trials that have been done to try to prevent the disease, as well as controversies and future directions for both therapeutics and workup. So just starting with a general case, this is something that we do see kind of regularly in practice. It's a 43-year-old with acute myeloid leukemia who undergoes haploidentical stem cell transplant following fludarabine and cyclophosphamide conditioning with total body irradiation. Graft versus host disease prophylaxis is post-transplant cyclophosphamide, tacrolimus, and mycophenolate. On day 16, a surveillance lab comes back for HHV6B at 15,000 copies. She's completely asymptomatic. Her ANC is 10 and her platelets are 10,000. Hepatic and renal function are normal. At this point in time, what would you recommend? And the answers potentially would be IV foscarnet, IV ganciclovir, a lumbar puncture, and if HHV6 is detected, starting foscarnet, or clinical monitoring, but no specific antiviral therapy. So if you can see at the top, the poll should be active, and the handle again is Guy Handley 812. Okay, so we got about 7 responses. So great, I didn't fool you. It's something that you'll see place to place, and we'll kind of go through the literature. I mean, I think for this particular patient, most of the literature is going to support option D, but it's not completely clear, to be fair, for clinical monitoring. So here's a second one. 65-year-old male with high-risk acute myelomonocytic leukemia undergoes prophylactic intrathecal cytarabine. He, for whatever reason, has a multiplex PCR for meningitis and encephalitis pathogen scent that comes back positive for HHV6. You're consulted for this, and which of the following would you recommend? Clinical monitoring, but continue his planned chemotherapy. Clinical monitoring, but hold the chemotherapy, or treatment with either foscarnet or ganciclovir. Okay, so everybody's kind of in agreement too. Kind of clinical monitoring and continued planned chemotherapy. So it's not exactly, but it's one of the ones that does show up on ID board exams sometimes. The virus itself, and we'll talk a little bit about the literature, you can detect it even in completely asymptomatic patients, like most DNA viruses. And so just isolation of DNA from a herpes virus or any really DNA virus alone is not sufficient to diagnose disease. The other issue that comes up with this question is the multiplex PCR panel, which I think we've all seen in practice, and certainly a lot of hospitals have it at this point. There's some controversy whether there are actually false positives with HHV6, and there are some kind of case reports of that. Whether it's a true false positive or you just detecting, DNA-emia that's not clinically significant is kind of debatable. There needs to be larger controlled studies, but you may get an ID board exam where it's sent on a patient who is not immunocompromised and has meningitis or something like that, and it comes back positive. And what they're really looking for you to understand is that just having it detected doesn't diagnose disease, and so you don't necessarily need to treat it. All right, and the last one is a 52-year-old male with AML who undergoes umbilical cord blood transplant after conditioning with busulfan, thiotepa, fludarabine, and ATG. On day 28, he develops confusion and seizure-like episodes. His neutrophil count is 600, platelets are 20,000, renal and hepatic function are normal. Which of the following do you recommend at this time? So IV phoscarnet, IV ganciclovir, combination therapy with both, or an MRI, lumbar puncture, and wait until you've diagnosed the disease with a test before initiating those two options. And I guess if they're negative, not treating it. I think this one's going to be a little bit more controversial. All right, so got a little bit of a split. So 2/3 say that, let's get a diagnosis before we start treatment. And then it is split between 22% with foscarnet, 11% with ganciclovir. I'll tell you that there's no right answer to this question, and we'll kind of go through the literature. Hence the split. For a patient like this with such a severe presentation, I'll go ahead and tell you the disease mortality is potentially so high and the outcome so poor that I probably would go ahead and initiate therapy. And I might even do combination therapy in someone who's seizing like this, and we'll kind of go through all the literature for that. But it is challenging, and that's certainly something that we have limited data for, and we'll kind of go through it now. That makes this such a hard disease both to diagnose and then as treat. There's no right answer. It's kind of, yeah, I think it kind of is clinical. We'll go through kind of the different reasons what you're thinking. So, yep. So Human Herpesvirus 6, it was first actually isolated in 1986. Obviously, it's been here with us a lot longer than that. And a patient with AIDS and a lymphoproliferative disorder. Almost all children are infected with this virus. When it's clinically presents itself, it's Rosella, but most patients actually don't have any symptoms. By the time you reach early, seroprevalence is almost universal. It's very rare to have primary infection in adulthood. So certainly for pediatric bone marrow transplant, this is much more of a concern for de novo infection than in adult populations. There are actually two distinct. By that time we'd already named HHV7 and HHV8. So instead of coming up with a different number that's referred to as HHV6A and HHV6B. It's a beta herpes virus, so that includes cytomegalovirus and your Rosella viruses, with HHV7 included. Reactivation occurs in completely healthy patients. It also occurs in sick patients, critically ill patients in the ICU. There's plenty of studies where they've actually just tested plasma for HHV6 and you can detect it. But it's rarely clinically significant unless the patient has heavy immunosuppression, such as a bone marrow transplant. And on the right, you just kind of can see a picture of Rosella. So we talked about early childhood, almost everyone gets infected. After that, like all herpes viruses, it establishes latency. Depending on if it's 6A or 6B, they use different receptors to enter cells. So 6A actually uses the CD46 receptor, which is present on all nucleated cells. 6B is a little bit more restrictive. Its primary target is CD134, which is found more commonly on T cells. That being said, they both can infect a very large amount of cell lines, despite this, preference for CD134. And that's been shown in vivo. It's just kind of in vitro studies, they have HHV6B has a preference for T cells. After primary infection, it integrates into the genome at the telomere region. Classically, that's described as PBMCs, but at the same time, we talked about it can be in a lot of different cell lines. What's very interesting is that it has not yet been shown to form episomes. So certainly our alpha herpes viruses, HSV, VZV, gamma herpes viruses, EBV, HHV8, those form episomes when they establish latency. This actually integrates into the telomeres. Not in this talk, but I know we did a multidisciplinary conference with our biology department last year. CMV is the same sort of thing. We kind of think it probably forms episomes, but that's not been clearly established like the other viruses. And it's kind of interesting. CMV is a beta herpes virus too. So what is chromosomal integration? This occurs in about 1% of the population, depending on which group you look at. But essentially that chromosomal integration, if it happens within a gamete and then that's passed on to the child, every single nucleated cell in your body is going to have a copy of HHV6. Well, when that happens, just because of normal cell turnover, you're going to pretty much have very high levels of HHV6 DNA that's detected in the plasma and in the CSF, everywhere there's nucleated cells. But because of that too, treating it is not often going to change the level significantly because you just have a normal amount of cell turnover in the human body. And if every cell has HHV6 DNA, you can see why treatment's not really going to affect the level as much. You can diagnose this. It's not done routinely in most labs. You're probably going to have to send it to a specialty lab like the University of Washington with droplet digital PCR or FISH, and just kind of demonstrating the integration in the region in multiple cells. This is a table from the European Conference on Infections and Leukemia. It's a guideline from 2019. We'll talk about it a little bit later, but not to get too bogged down by the details going through it, but it can kind of show you, if you do suspect chromosomal integration, how to kind of work through that and look, is this donor or recipient, both, and then kind of put a time frame for the infection. I will say it's not harmless. There was a paper put out in 2017 that having chromosomal integration is associated with higher rates of graft versus host disease and viremia after bone marrow transplant. Just not clear how we would act on that clinically. And so because of that, it's still not routinely tested in patients. So we talked about reactivation. The vast majority of reactivation disease is from HHV6B. Part of that is because HHV6A is generally transcriptionally silent. It gets highly condensed with histone modifications. The most classic, well-defined presentation is encephalitis after stem cell transplant. The European Conference on Infections and Leukemia kind of comes out and says, it's not likely to cause disease in patients without hematologic malignancy because you do have to have a very high level of immunosuppression to make that jump from asymptomatic DNA to true disease. In terms of encephalitis, depending on the patient population, what type of transplant they got, the frequency and incidence differs, but it seems to be somewhere between kind of 1% and 2% of all bone marrow transplants. But reactivation is much more common. So reactivation of the virus in plasma occurs in about 30 to 70% of patients after transplant. This usually happens within the first month, but most are asymptomatic and resolve without any sort of treatment or intervention. In terms of reactivation, this is one of my favorite studies. It came out in 2018. Essentially, we monitor for CMV reactivation after bone marrow transplant. They took those samples and then started testing them for other DNA viruses. So BK virus, HHV6B, adenovirus, EBV. So a lot of these patients aren't, they're not treated. This is kind of done separately in the lab. The test was done just for CMV monitoring. And what they found is for HHV6B, about 44% of those reactivations that occur are a single test, which they defined as a blip. So this, weekly monitoring. And only 23% of them had detection for over 4 weeks without treatment. So, most are just going to be the single test and it's going to kind of resolve, but even a decent proportion stay positive for over 4 weeks. The very interesting thing on the panel on the left, you can see is that no patients who had just a blip, that was 95 of them, developed some sort of end-organ disease. In the patients who had persistent viremia, so over 4 weeks, that was 90 patients, only 3.3% developed disease. So just having viremia itself is a very poor predictor of developing disease. Only 3.3% of patients who develop persistent reactivation are even going to go on to develop disease. Another thing too is having reactivation bad. So on the right, they looked at overall mortality at 1 year divided by day 0 to 100 compared to day 101 to day 365. HHV6 is right in the middle. Early reactivations weren't actually associated with any increased mortality at 1 year. But reactivations after day 100 did trend towards a worse outcome. Now, there's a lot that goes into that. Is that, poor immune reconstitution? Do they develop graft versus host disease and are getting further immunosuppression? Do they relapse their cancer? So it's not a cut and dry HHV6 is causing this. Certainly, reactivation later probably associated with a worse outcome. But the important thing is early reactivations aren't necessarily associated with increased mortality. And that's when we see a lot of these patients while they're in the hospital or waiting for their neutrophils to engraft and making kind of recommendations. You can kind of see from the other herpes viruses, cytomegalovirus, early reactivation is actually associated with increased mortality. Adenovirus, same sort of thing. Epstein-Barr virus, especially with PTLD, if you have that early reactivation, is kind of concerning and certainly high-risk patients. And for some of those, we even give prophylactic. I've talked kind of the EBV lecture. One of the biggest challenges with our testing platforms, y'all probably seen this, you send it off, it's going to come back in a week. When patients actually develop disease, the viral kinetics are that the virus tends to rapidly rise within 48 hours of the onset of symptoms. And so if I have a test a week to come back, it's going to be very hard to use that to predict that rapid increase that's going to kind of herald symptoms. This is just a couple studies from Dr. Ogata's lab that just natural course of the virus. So you can kind of see it will peak really highly right before they develop CNS symptoms. The CNS, they didn't check CNS before they developed the symptoms. So a lot of times you'll see that, but you can see how quickly it falls too. And the arrows are when they had CNS dysfunction. So this is another one from the same group, earlier paper, just kind of course of the virus detected. You can see it tends to just spike and then resolve on its own. But the point from this is it's just very hard to use your preemptive monitoring or test strategies. It takes you longer than 48 hours to get that test back just because of the natural course of the virus. These are some associations that are reported as possible presentations of HHV6B after stem cell transplant. Again, encephalitis is by far and away the one with the most evidence, and you can see there HHV6B, very strong association. For HHV6A, we talked about how it's heavily histone modified. It's usually transcriptally silent, so it's kind of harder to tie that to actual disease if you're detecting that. And some assays will actually give you is this HHV6A or B, including the one we use at Moffitt from ARUP. In terms of other disease states, the evidence kind of ranges. I did put stars next to a couple of them, fever and rash and myelosuppression. So we do know that, in vitro, it can lead to lymphocyte suppression. It can lead to actually platelet suppression. However, it's hard to prove a direct causal link, and it's not even shown with neutrophils that HHV6 reactivation direct causal link. It's just associated with poor platelet engraftment, and in vitro, it can inhibit lymphocytes as well. In terms of fever and rash, studies are kind of mixed. There are some studies where they did biopsies of patients who developed a rash after transplant and were able to detect HHV6 DNA. There's other studies that they had HHV6 in the plasma, but when they actually did a biopsy, the HHV6 antigen in the rash was, or the tissue from the rash was negative, and they had graft versus host disease. So a lot goes into that. A lot of those earlier studies that did detect HHV6 DNA didn't look for chromosomal integration too. So, if I'm chromosomally integrated, every cell in my body, including all my skin cells, potentially are going to have HHV6 DNA too. So I'll say it's a possible association. It's very controversial. There are a lot of other things that can do it, whether that's chemotherapy, graft versus host disease, and a lot of times just because asymptomatic viremia we talked about is so common, you really have to do a thorough workup to determine the difference. So focusing on the disease state that we have the best association with, this is something that might actually show up on an ID board because there is so much data behind it, is encephalitis. So established risk factors: mismatched donor, myeloablation, cord blood, male gender, low titers pre-transplant, high doses of steroids, or higher grades of graft versus host disease. There is a pretty well-defined syndrome called post-transplant acute limbic encephalitis, or PALE. The classic symptoms are kind of anterograde amnesia. They can kind of tell you stuff in the past, but if you tell them or ask them to remember something, they can't. Temporal lobe seizure activity, enhancement in certain areas of the brain, whether that's the hippocampus, amygdala, uncus. It's important to note that your initial MRI or EEG may actually be normal. So they may have this anterograde amnesia or altered mental status. You get an MRI and it's normal. But they can develop those changes on subsequent exams. So it does seem that a lot of times symptoms may appear prior to actually the things you may see on imaging or an EEG. But as we know too, especially early in the transplant period, there's a lot of things that can cause altered mental status, whether that's calcineurin inhibitor toxicity, PRES, strokes, other viral infections and reactivations. And so you have to work through all of those before you can kind of call it HHV6 disease. This is a major study from Josh Hill up at Fred Hutch from 2012. It really just showed how high of a risk factor cord blood transplant is. I mean, it was a hazard ratio of 20, even compared to some of the other things like graft versus host disease or mismatched donors. Cord bloods, we don't do a lot of them anymore, especially with kind of haploidentical transplantation, but it is something to just kind of know it's a very, very high risk of HHV6 encephalitis. These are some pictures of kind of different patients with HHV6 encephalitis. So the panel A and panel B, you can kind of see that classic hippocampal enhancement. That actually might show up on a board exam. They'll give you a patient who's after allogeneic stem cell transplant. They'll throw up this picture and they'll give you, HSV1, VZV, HHV6, and toxoplasmosis. And they're really showing you kind of that hippocampal enhancement, that well-defined pale syndrome, and wanting you to go for HHV6. But I do want to highlight there's a lot of other things you can see. So certainly panel C, you can just have these changes up in the supratentorial region that are nowhere near the hippocampus. It's not, in most patients that I've kind of seen in practice don't have, this perfect hippocampal enhancement. It's just something that's kind of highly associated with it. And for ID boards, that's always a target for questions. So over time, we kind of started defining high-level reactivation as having over 10 to the fourth copies per ml. I'll kind of show where that came from. So early studies showed that higher DNA levels in the plasma correlated with CNS symptoms. This is before we had definitions for pale or, anything like that. And they didn't look to say, does it correlate with HHV6 encephalitis specifically, just some sort of CNS dysfunction. In 2013, there was a study that showed in patients who had less than 10 to the fourth copies, which was 144, there were 0 cases of HHV6 encephalitis. In patients who had over 10 to the fourth copies, there was 8.1% of those 86 patients had encephalitis. So, and that was statistically significant. And this is kind of where the establishment of 10 to the fourth as a cutoff came from. And for a lot of time, and it still does show up in the literature, if you were less than 10 to the fourth, does that rule out disease? If you're greater than 10 to the fourth, do we need to go looking for disease? Some of the problems with that study in the patients, so, we said 8.1%, but the 13 patients who had CNS dysfunction and high-level reactivation, not all of them had LPs, only about half of them. And the flip side, too, in patients who had less than 10 to the fourth copies in plasma and CNS dysfunction, less than half of them had a lumbar puncture. So, yes, 0% of them had HHV6 encephalitis, but we didn't even look at half of their CSF. And so it's very hard to kind of establish a 100% sensitive or specific threshold without actually looking for the virus itself, as well as just ruling out alternative causes, which we talked about. There's a lot in this period. So after that, Dr. Ogata, who did his lab, put out that kind of landmark paper that kind of set up the threshold, has had subsequent studies where, this one in 2018, we'll talk about later, 5 of the 7 patients with encephalitis did not have high-level reactivation. In our case series at MD Anderson, we had a pretty strict definition for HHV6 encephalitis or meningitis that went beyond just detecting it in the CSF. But 10 of our 13 patients did not have high-level reactivation in the plasma, so certainly a poor predictor. And we actually had 2 of the 13 who had isolated CNS reactivation, so negative in the plasma, but positive with some form of testing in the CSF, whether that was separate PCR or by the meningitis encephalitis panel. So really a big thing to take away from this, yes, high levels in the plasma do probably correlate with CNS disease, but I don't have a threshold that's sensitive or specific enough to rule out HHV6 encephalitis or rule the disease in. Another challenge that goes even beyond this is there's no standardization for HHV6 like there is for CMV and EBV. There's no international units. 10 to the fourth on my assay may be different from yours, ARUP versus Viracor. And so it gets very hard to use that in practice if your testing is going to be different based on which platform you're using. This is another one of my favorite studies from Dr. Hill's lab that was published in 2014. They basically looked at just CSF in patients both with and without CNS symptoms. To draw your attention to the top 2 panels, so the left one is plasma HHV6, the right one is CSF HHV6. And the last 2 columns you can see are either patients who do not have any neurologic symptoms, or it's spontaneously resolved, or they had another etiology, but you can tell that there is still HHV6 in the CSF of those patients. And that's a logarithmic scale on the side too. So even up to 10 to the 5th, with an alternative diagnosis, spontaneous resolution, or no neurologic symptoms. So big thing to highlight from this is that just detection of the virus itself, even in the CSF, is not sufficient to make a diagnosis of disease. You have to have some sort of symptoms. Like any DNA virus, you have to have detection and some sort of end organ dysfunction, some sort of disease state to make a diagnosis. So moving on to treatment, I will tell you there's no guidelines for how to treat HHV6B outside of encephalitis. There's a few for encephalitis itself. They kind of recommend foscarnet at full dose, 90 mg per kg Q12 hours, or 60 mg per kg Q8 hours. Ganciclovir as well is listed as a potential first-line option at 5 mg per kg Q12, which is a full dose. Cidofovir is kind of listed as a second-line agent. Part of that's because the CNS penetration is poor. We don't have as much data with it. And then most of the guidelines do kind of say, hey, if it's a severe case, you can consider combination therapy, and we'll go through some of the literature. But, the third question that we had on the poll everywhere kind of gets to this. There's a lot of those options that are okay to use. There's no kind of consensus for the best way to go after it. In terms of how long to treat it, generally the guidelines will say 3 weeks to show clearance in plasma and the CSF as possible. That's not necessarily data-driven. It's just kind of more expert opinion based on kind of clinical experience. I put this slide in here because it's a pretty interesting study in 2006 that sometimes goes for why providers will choose foscarnet over ganciclovir. A lot of times early in bone marrow transplant, they're cytopenic. You don't want to use ganciclovir anyway because of the risk of myelosuppression. But the top panel is looking at HHV6A. The black bars are actually T cells, and then the white bars are astroglioma cells. So for HHV6A and T cells, foscarnet and ganciclovir actually inhibited the virus better than the other agents. And so, the y-axis is actually a logarithmic decrease in the viral load. So the higher it is, the better the drug is actually treating the virus. For astroglioma cells, though, foscarnet and cidofovir actually perform better. So kind of interesting. For HHV6B on the bottom, which I think is more clinically significant, we talked about HHV6A is usually transcriptionally silent. In T cells, all the agents are kind of similar. Cidofovir maybe a little bit lower. Infection in astroglioma cells, though, is actually abortive. And so it's very unclear the clinical significance of this, but it is just kind of important to note, at least for HHV6B, foscarnet, ganciclovir, even, acyclovir does have an inhibitory effect, and they're not substantially different in T cells. In vitro, importantly. In terms of outcomes, so this is why there is such a push to look for this virus, treat it, is because the outcomes are very poor with HHV6 encephalitis. This was a study put out in 2017, one of the largest cohorts, 6,593 transplant patients, 145 with encephalitis for a percent of 2.3%. None of the cases were HHV6A. All were either HHV6B or just undifferentiated. The assay didn't tell. The day 100 survival for patients with encephalitis was 58.3%. That's compared to 80.5% in those who did not develop encephalitis. So pretty severe, poor outcomes. If you survived, you still 57% had neurologic sequelae long term, which, it's even if you're able to survive this, potentially going to have a bad outcome. Certainly this mirrors HSV1, for example. If you don't treat that, those patients do very poorly, but those who do survive tend to have horrible sequelae too. In terms of the sequelae that they may have, a lot of times it can be just kind of memory impairment, lethargy, kind of, very nondescript symptoms. But I think the biggest thing to look at from this paper in terms of the neurologic sequelae is the last circle. Nearly 4 out of 5 patients were unable to return to society, which the paper defined as, be able to go back to work, school, or their household activities. So a lot of long-term after effects in survivors with true HHV6 encephalitis. And that's part of the push for, what can we do to treat this? What can we do to prevent these side effects, improve patient outcomes? This is where the recommendation for full dose treatment came from. It's just looking at different dosing of foscarnet and ganciclovir. You can see the response rate increases as your dose increases up to the last column, which is full dose treatment. It was statistically significant, using full dose treatment. You had a better neurologic response. as well as kind of the composite endpoint of lower rates of death or sequelae due to encephalitis. In this particular study, and this is another reason phoscarnit's a lot of times used as first line, use of phoscarnit itself was independently associated with improved survival at day 30. And ganciclovir was actually associated with a reduced overall survival. They kind of speculated maybe this was due to poor CNS penetration, myelosuppression. But when you truly look at death due to HHV6 itself, which is the first column, it wasn't statistically significant getting ganciclovir phoscarnit. It was just kind of overall death from any cause at day 30. You tend to do better if you got phoscarnit, and ganciclovir you did worse. So, certainly the myelosuppression may come into effect. A lot of other things can kind of go into there. And then in terms of neurologic symptoms, comparing ganciclovir monotherapy to phoscarnit monotherapy, there was no real difference in outcomes with neurologic symptoms. You can kind of see it was 83.8% versus 71.4%. A lot of these patients, or not a lot, but a few of them got combination therapy, 10. So in this study, they reported that there was a 100% response rate. It wasn't really, enough patients to kind of dive into do a statistical analysis, but something to kind of consider in the combination therapy patients, that response rate. This is another study put out in 2017 looking at combination therapy. It was a meta-analysis of a bunch of different cases. Combination therapy seemed to reduce sequelae, but they weren't able to show a survival benefit necessarily with it. So that's why it's kind of debatable. A lot of it depends on the severity of the symptoms in the patient. So moving into that, there's a push to, we talked about how horrible the outcomes are with true HHV6 encephalitis. We also talked about how we have a lot of challenges even making the diagnosis. Reactivation is extraordinarily common. Blips are very common, and they don't actually predict disease. Even persistent viremia is not really going to predict disease too. And so there was a push because of the poor outcomes to say, hey, can we preemptively monitor and intervene to prevent this, or prophylactically treat patients to prevent development of disease? So this was one of the first ones. It was in 2008. It was a prospective study of stem cell transplant patients. About 35% of them were cord bloods, but not a high amount of numbers overall. So 19 of them were positive. They waited until they developed high-level reactivation and then preemptively started treating them with ganciclovir to try to prevent disease. They weren't, it's a low amount of patients, but they weren't really able to show it prevented disease. And actually the two of the patients who developed encephalopathy developed it before they reached that high-level viremia. So this was the second one in 2011. They looked at a bunch of different patients, but kind of did their analysis on just the cord blood patients in the study, which is 15. They performed weekly plasma monitoring and initiated phoscarnit at 500 copies per ml, which is a pretty low cutoff. 80% of the patients of those 15 developed DNA-emia. We talked about cord blood's a risk factor on its own developing disease, and with a very high odds ratio. They treated about half of them. Only one patient developed encephalitis, and it was actually in the treatment arm. So they weren't able to show a benefit of preemptive therapy, and even at a very low threshold of DNA-emia. The risk is phoscarnit and ganciclovir. They're not benign medications. They have a lot of potential side effects, whether that's, in the case of phoscarnit, nephrotoxicity or electrolyte issues. And, that they didn't do a full statistical analysis, but did kind of comment there was potentially more grade 2-3 side effects in the patients who did receive phoscarnit. This isn't a preemptive study per se, but it's one from 2014, which is another one of my favorite studies from Sloan Kettering. They looked at 125 double cord blood transplant recipients. So this is very, very high risk of HHV6 encephalitis. They prospectively monitored them for 1 to 2 times per week. 94% of them reactivated HHV6B. So nearly everybody in the study. The median peak was 7,600 copies per ml, but it had a very wide range. And then that 10 to the 4th cutoff of which is still in the literature, is high-level reactivation. 40% of them, or almost 41%, met that threshold. They didn't do a statistical analysis, but looking between the observed patients, which was 79, and the treated patients, which was completely up to the treating physician's discretion. This is a retrospective study. You can tell that the viremia duration's not really different. The day of the peak is kind of similar too, but understandably, treated patients were more likely to have a high amount of peak copies per ml. It's made by a clinician. The higher it is, I think everybody has a little bit of a bias to kind of lean towards treating it. They didn't really have any cases of encephalitis, though, so they weren't able to kind of show if treatment had any difference because they didn't have enough cases to even make it, despite cord blood transplant being such a high risk. The important thing I'd take from this study, though, is they did a Cox regression analysis of high-level reactivation, so over 10 to the fourth copies, compared it to low-level reactivation, and they found no difference in engraftment, either neutrophils or platelets, graft versus host disease, higher grades at day 100, transplant-related mortality, or 1-year disease-free survival if you had high-level reactivation. So this is kind of additional hard endpoints after bone marrow transplant, in addition to that study from Dr. Hill's lab I showed you that didn't show any mortality with kind of early reactivation, that just having a blip, even a high level blip, isn't necessarily going to portend a poor outcome for the patient. And there was also no difference in 1-year disease-free survival in treated patients compared to observed patients, and you can kind of see those statistics there. So then moving on to prophylactic studies. Okay, so we're going to treat these patients before they even reactivate. This was a study from 2013 that looked at 118 stem cell transplant patients, kind of pretty heterogeneous group. 67 of them received an intervention, which was foscarnet at a lower dose for 10 days at start day plus 18, or at PMN engraftment if that occurred before day 18. They excluded patients with creatinine over 1.6. What they found, though, is if those patients got the drug, there was no difference in high-level reactivation, although it did tend to be lower, and there's no difference in HHV6 encephalitis. There was a substantial amount of side effects. They didn't, do a full analysis to kind of say was foscarnet the cause of it, but 31.3% of patients developed grade 2-3 nausea, and 4.5% of them had an increased creatinine. And overall, 16.4% couldn't tolerate the drug itself from kind of toxicities decided by the treatment team. They actually had to stop it. So another prophylactic study in 2018 from Dr. Agata's lab, the same group, was a multi-center trial looking at cord blood transplant, so very high-risk group. They looked at 57, compared it to a historical control that did not receive an intervention, which was foscarnet at full dose, but only once a day, from days +7 to 27. And in this, 23% were unable to kind of complete the full 21 days from various either toxicities or the clinician deciding they couldn't. There were still 8.7% of patients who developed HHV6 encephalitis, 5 of the 57 total. And 8% developed some sort of AKI. Nearly 1 out of 5 doses of foscarnet required renal adjustment because of renal dysfunction. And there was a decent amount of grade 3 events, as well as a few grade 5 events, including myocarditis, pneumonitis, and heart failure. But they kind of had a consensus review board that felt it was probably not due to the foscarnet itself. So what did they find from the prophylactic treatment? There was a lower rate of high-level reactivation, so that 10 to the 4th threshold, by day 60, but it was only statistically significant at the time points of week 3 and 4 for high-level reactivation. Past that week 4, there was no statistically significant difference in high-level reactivation rates, and then before it too. So kind of this very fixed time point, prophylaxis may have prevented high-level reactivation. But if you look at encephalitis, which was kind of the goal of the study is to prevent disease, there was actually more cases of encephalitis in the treatment arm who got the prophylaxis. I'm sorry. It wasn't statistically significant, but it is, kind of notable and something to kind of be concerned about. It at least, I think points out that it probably didn't prevent disease. 3 patients died during the follow-up period. They, the board said that they didn't feel like it was due to HHV6, but they didn't really kind of go into it in the paper in depth. Also, high grades of acute graft versus host disease, no difference if they were prophylactically received foscarnet. So kind of that's the literature behind preemptive and prophylaxis therapy. There's a few other studies that are not necessarily as controlled or, don't have a control group that I didn't kind of go into, but based off of those that I showed you, there are 3 kind of guidelines. One's from the European Conference on Infections and Leukemia that was put out in 2019. It gives guidelines for all allogeneic stem cell transplant patients. It's kind of a very comprehensive HHV6 guideline. It's probably the one I refer to the most. The Japan Society for Stem Cell Transplant in 2019 has one, but it's kind of specifically for encephalitis. So it doesn't go into all the other, chromosomal integration workup or other types of possible infectious presentations. But it does give a lot of information for encephalitis specifically in terms of kind of treatment recommendations and how to follow those patients. And then the American Society for Transplantation and Cellular Therapy has a guideline in 2021, but it's specific to cord blood. It's not, your haplos or your matched unrelated donors, those kind of things. So one of the best comments I ever got from a reviewer was, "Can you make a chart of that?" And so this is kind of just summarizes all of those guidelines, looking at kind of what are accepted risk factors, when should you look for chromosomal integration, and a lot of that's just based off of if they're persistently staying at this very high level, 10 to the 5.5 or 10 to the 6, treatment recommendations and the evidence behind them. How long should you treat? Pretty much all of the guidelines do recommend, based on those studies I just showed you, against prospective monitoring, so even trending HHV6, preemptive therapy, prophylactic therapy. The one exception kind of may be that the Japan Society of Stem Cell Transplant, as well as ASTCT, do say, hey, for these very high risk patients, we don't have enough data. It may be reasonable to monitor for viremia, but then they also acknowledge that there's no data to support when those patients do develop viremia actually intervening to prevent disease. So a little bit controversial. We need a lot more data, especially for the newer things like haploidentical transplant, to see does it line up with the rest of the patients. So controversies and future directions, kind of finishing up. We talked about HHV6A is heavily histone modified, usually transcriptionally silent, but there is some debate, like, can you truly develop HHV6A encephalitis? Certainly the rate is far lower than HHV6B, but it is something that's kind of debatable. At the vast majority of the time you detect HHV6A is either going to be chromosomal integration or clinically insignificant, as well as can you reactivate from chromosomal integration? Again, most of the time it's not the cause of a disease, even in a patient with encephalopathy or some sort of CNS dysfunction, but there is some debate of, hey, can it actually reactivate from that telomere and start causing issues? Pneumonitis in terms as a presentation of HHV6 is debatable too. It's kind of a diagnosis of exclusion. I can tell you I've had a patient who I think died of this when I was a fellow. It had multiple workups, everything was negative, and their HHV6 in the bronch as well as the plasma and just kind of everywhere was through the roof. And they did have negative values at one point, so it'd be hard to kind of say this is chromosomally integrated if you have a negative test at some point. But again, very hard to diagnosis of exclusion. We talked about the problems with our diagnostics. I think y'all probably saw Moffitt. You send this off, it takes 5 to 7 days to come back. We don't have international units, so it's hard to compare between sites. I didn't go into it, but there's even discordance among testing platforms. So I've had patients who you send the separate PCR test to a reference lab, and then you do the meningitis encephalitis panel in-house, and one of them's positive, one of them's negative. I've even had patients who've had classic symptoms, and then the second test that was negative turns positive on a subsequent check. And so that's another kind of problem that may happen. Is it possible, like HSV1 or another herpes virus, to develop symptoms before you can actually have detectable DNA at a threshold that would trigger that test to turn positive? We don't have any validated thresholds. We talked about the problems with high-level reactivation in terms of, high levels in the plasma probably you're more associated with developing encephalitis, but I can't give you a number that's going to completely rule it in or out. So there's a push right now to kind of improve our predictive models. So it does seem like that hyponatremia may precede development of encephalitis in some patients. It's certainly not 100% sensitive or specific, so it's just one piece of the puzzle. These patients have a lot of reason to get hyponatremic, and a lot of people are hyponatremic and never develop HHV6 disease, so it's just kind of one small thing. Post-transplant cyclophosphamide, which has been great for graft versus host disease prophylaxis, but it probably does increase your risk of developing herpes virus infections, as well as the ELISpot, which essentially is a test that shows, are you developing some sort of immune reconstitution? If I know you have an immune response to HHV6, I do feel, that's probably protective, and it has been shown for other herpes viruses. And then in terms of therapeutics, cytotoxic T lymphocytes, so if I have T cells that are primed to attack HHV6, could those be used? Unfortunately, the trials that are ongoing right now for kind of the most widely spread commercial product were not super successful, and they've kind of been stopped, some of those phase 3 trials. So that modality is going to be the future is going to be in doubt. It's going to be kind of interesting to see what happens there. So in summary, HHV6B frequently reactivates after transplant. Again, 30 to 70%, even up to 94, 95 in those double cord blood transplants from the Sloan Kettering study I showed you. Of those, most are just a single test. It's a blip, it goes away. But even in the patients who do have persistent viremia, only a small percent are going to go on to develop true disease. We mentioned all the limitations of our testing platforms, but the disease itself, especially encephalitis, the mortality and morbidity is so high that, we really want to try to intervene and help these patients when we can. It's just we don't have any way to predict who's going to develop disease based on just testing for the virus itself. We talked about how combination therapy may have a role, not necessarily been proven to improve mortality, but maybe neurologic sequelae. And then we went through all the preemptive and prophylactic controlled studies that they really haven't shown a benefit of doing that to actually prevent encephalitis or transplant-related outcomes. And that's why it's kind of not recommended by consensus guidelines for routine patient care. So with that, those are my references, and I'm happy to take any questions.